welcome everyone. So you eat stuff before you go on holiday. On weekend. So this is our third science symposium, and again to remind everyone, the idea is for us to all know each other, people who work in this building, and perhaps in the wider research park area. Just a reminder, we do have a lecture in August. Adam Andreska will be presenting. In September will be AIMI, and then October 1st, Danny Chu. So keep that in mind. We're not skipping any months in the summertime. And with that, I'd like to introduce today's speaker. So it's my pleasure to introduce Ashwin Kumar, who's representing AIMI, the Artificial Intelligence in Medicine and Imaging Center at Stanford. And Ashwin is actually a fourth-year graduate student, and he's here at Stanford. He's working on developing deep learning methods, advanced medical imaging, acquisition and analysis. So it's a topic that we haven't heard before in this symposium. Ashwin has received numerous awards, including the Goldwater Scholarship, the Tau Beta Phi Fellowship, and the Stanford Knight Hennessy Fellowship. So we'd like you to welcome Ashwin. If you have questions, please do ask, whichever way you like it, at the end or in the middle. And for people on Zoom, I don't know if we have anyone, they can post their questions in the chat. And Ashwin, so it's all yours.
Awesome. Good afternoon, everyone. Excited to present some of the work today. I'll be talking about the title of this talk is a bit broad about teaching medical AI new capabilities. It's really going to talk a bit about our work on Merlin, which is a paper recently published in Nature. And it includes a lot of collaborators across several different institutions, but hopefully I can make it a bit more digestible, just so that I have a good framing of what the audience is here. How many people are familiar with AI technologies or like work with AI technologies? Awesome. And out of that, how many are familiar with like medical AI technologies? Amazing. Okay. So I'm going to be talking a bit about like general clinical stuff as well, and probably I hope to give an intro. But if there's any questions about any of the topics, just feel free to let me know. I'm happy to answer any questions. And I've timed this to be around like hopefully within like 20, 25 within that time frame. But if there's more questions, or even there's also some more content that's there too, and people want to learn more, then I'm happy to share some more slides. So great. So I wanted to first begin with an example clinical workflow. So it could be good to just introduce everyone to the concepts of this work. So let's say you have a patient that arrives to the emergency room with abdominal pain and vomiting. Whenever that encounter occurs, there's also an EHR record that is fully populated with the patient coming in. So there will be like diagnosis codes. But let's say afterwards, a triage nurse may note high blood pressure, and that is also noted in the EHR. And maybe after that, an emergency physician orders a CT scan of the abdomen, and a radiologist also may find pancreatitis and a renal cyst. And all this stuff is included part of the diagnosis codes of your electronic health record, but also part of the radiology report, in which it may say that the patient has pancreatitis and incidental finding of renal cyst. Of course, simplified, but whenever you think about data coming in, right, and as soon as they walk in, you have an EHR that's populated. And in these emergency room situations, you can already see that we are getting data even before we are seeing the physician. And so if you can think about this over time, how many times this happened, there's been a lot of data that has been accumulated and for us to use. So that's precisely what happens. The collected data over the years is multimodal in nature, meaning that it's not just imaging and can be placed into imaging, unstructured EHR and also structured EHR. Imaging for us, we're going to be talking about abdominal CTs, but unstructured EHR can be considered the radiology report. Why it is unstructured is because it is free text, and so there's not any sort of predefined structure to the actual data. And then you also have structured EHR, which may include diagnosis codes that consist of a lot of different indications that the patient has actually been assigned during their actual emergency visit. And if you think about it, there is a lot of unstructured EHR and a lot of structure that has actually been placed on the clinician to actually write up because it is a radiology report. And this does cause to a lot of burden. So radiologists over the years have been having an increasing workload. So just within the US, there's been 85 million CT scans and around 300 million CTs globally. And there's around a 6% annual increase in the number of CT scans. And if you use the rule of 70, which is really common in investing, we know right away that a 6% increase per year means that this number doubles every 10 years. And things that radiologists don't have a lot of time to read the CT scan. There can be 300 slices. You only have around 20 minutes for interpretation, and they have to write a radiology report in that time frame as well. And it doesn't look like that there are going to be more radiologists to really help with this. Since 2003 to 2020, there's been the number of actual radiologist residency positions has been fairly stagnant. And there's a lot of open jobs for radiologists. And to keep up for future demand with this amount of CT scans that are increasing, radiologists may lead to actual burnout, which does not help us solve our potential problem. So what does a radiology report exactly look like? So your radiology report is going to consist of two different sections. You're going to have the findings section as well as the impression section. The findings section is going to consist of all different kinds of notes they may actually have or see inside the radiology report. And the impression is a very simple summary of what exactly is going on with the findings. It may actually include some sorts of the indication or whatever they may have for the patient and put that in the impression section. But if you think about it, the information you get is kind of limited. All it is just the radiology report that you're really getting. And if you think about it, we can perhaps augment this kind of workflows that are there. If you have the patient plus the CT scan, you can think about what medical AI can actually do. And it can go beyond just thinking about the radiology report. I mean, we can have, of course, the radiology report, but maybe you also want to retrieve similar radiology reports so that the radiologist has some kind of basis to use. You can also do perhaps organ segmentation, in which you can perhaps do volume level or get a certain organ that is interested for the radiologist. Or you can maybe do future disease prediction. So thinking if you have the actual CT scan, maybe you can look in the future and see if they have diabetes, maybe osteoporosis or other kinds of markers of long-term disease. And potentially even reduce billing errors. One of the things with these structured EHR or the ICD codes that I was mentioning before is the fact that they do use those codes for billing. So perhaps helping these kind of workflows can really help reduce these kind of errors. So not only that, not only thinking about how you can go beyond what the radiologist already does. And we can return back to our multimodal data corpus to really think about these principles. We can use AI principles to create a better clinically useful representation that can help us augment these clinical workflows. So we can take all of this unstructured EHR, structured EHR, we can link it together in imaging, and that is the basis of Rolling, which is the work I'm going to talk about. But to go back to kind of the topic of what we were kind of discussing, what does it really mean to teach AI something new? And the way a lot of researchers and the way we've been thinking about the research domain is that we can boil it down to kind of two steps. There's kind of the capacity step, and then there's kind of extracting a skill or developing a capability. So the first stage we consider pre-training. So what this is going to do, it is going to be consistent of this idea of self-supervised learning, which is using a large data corpus. For instance, in our example, it is this huge data corpus consisting of imaging, unstructured EHR, as well as structured EHR. And the goal of this is to build this general purpose representation of all the data that exists in the domain. So you're teaching this model the capacity of the whole data distribution. So your model is going to learn in pre-training, what exactly does a CT scan look like? What language co-occurs with the findings as well as with the images? And how does anatomy vary across patients? And all of this stuff is going to just give us this broad statistical mapping of our data. But then to actually fill in the gap, you're going to do our second stage. You can call this fine-tuning, you can call this probing, you can call this prompting. But in reality, all it is going to do is teach the model the actual capability of what it's going to do. It's going to turn that general representation that we get in pre-training, and it's going to make that into a specific nameable task that you can actually use. And this capability gets extracted from that capacity. So you may now ask the model to detect atelectasis, or you may ask it to write a report, or you may be able to track the change over time. And you can pull out the skill from this larger capacity of the model. So that is what it really, this basis of this work is going to talk about. It is first, we're going to talk about building this capacity, right? How do you build this large scale training? And then from there, each of our separate tasks are going to extract certain capability. So that gives us a nice overview of Merlin. In Merlin training strategy, we are leveraging unstructured and structured EHR data. The diagnosis codes from EHR are used as labels for Merlin training, and we use a specific loss for that. And the radiology reports are also used for training using a separate contrastive loss. And training with diagnosis codes and radiology reports is either staged or performed in a multitask manner. And the goal of Merlin is that this pre-training allows us to have improved performance on these non-adaptive tasks, as well as these adaptive tasks. These non-adaptive tasks and adaptive tasks. And so non-adaptive tasks are tasks that don't need any sort of architectural modification. They actually occur directly from pre-training. So that's a great assessment of our capacity. And then our adaptive tasks are a great measure of our capability, or tasks that are include adaptation. So non-adaptive tasks, which I'll talk about in this talk, will include zero-shot findings classification, diagnosis code prediction, and in adaptive tasks, we'll talk about 5-year disease prediction. So let's go ahead and talk a bit about exactly how you train this capacity. So we're going to go ahead and talk a little bit about supervised learning, which is something in the general domain of machine learning. So in supervised learning, you basically going to have what we call a batch of images, and you're also going to have a batch of labels. And the goal is you train this all together, and you're going to get our model. And if you think about it, we can now think about these labels as having, for instance, the picture of a dog as well as the label of a dog, or maybe a picture of a cat and the label of a cat, and a picture of a hot dog and then the label of a hot dog. But the thing is that in the medical domain, a lot of these labels are really expensive. But we do have a lot of unlabeled data, like what we were saying before. Like it's expensive to ask a clinician to generate a label for us. So how do we think of actually training strategies to actually leverage this? And what we really do is actually just get rid of these explicit labels. And that's just how we're going to transfer ourselves from supervised learning into this idea of self-supervised. So in our first step, you're going to have a batch of images. But what you're really going to have is a batch of pseudo labels. So we're going to create a certain set of labels to pair with our batch of images. And to combine these together is going to get us a pre-trained model to build us this capacity. And then our second step is we're going to build out this capability in which we're going to have these images, and then we're going to have these specific labels, which is the model. So in our case, right, if we go back to this dog example, we're going to have our actual our data set is multimodal, right? So let's say an image of a dog is paired with a word dog. In this case, our model is going to learn how to align our images and our text together. And it's going to learn these representations during pre-training. So that way, it's not just memorizing pixels. Instead, what it's going to do is going to connect the concept of a dog to the from both the visual and as well as the textual cues of the actual dog word. So you're going to go to the dog. You're going to have a lot of dogs. But then our pseudo label is going to be that actual text of a dog. So it's going to pair these things together. And the principle of pairing them, I'm just going to stop for questions if anyone has questions. Real quick. Okay, great. So the principle of pairing these together occurs in this idea of contrastive language image pre-training, or CLIP. The goal here is to learn what image corresponds to what text, and vice versa. So essentially what we're going to do is pass our images through this idea of a image encoder, and also going to pass our text through this idea of a text encoder. And what we're actually going to learn during training is we're going to have this diagonal matrix. And the goal of this is that we're going to maximize the on-diagonal components, and we're going to minimize the off-diagonal components, which can be done using a contrastive loss. And the goal is that both of these embeddings should be enriched by the other. And by leveraging the multimodal pairing early in training, the model builds a richer, more transformed representation that can be used in fine-tuning later. So the benefit of this is that you allow to get zero-shot image classification. Directly from the model, you can understand whether to classify a dog or a cat. In our case, we're going to be able to understand how to classify disease. We also get the sense of multimodal embeddings. You get both images and you also get text, and both of these are good representations of the underlying data. You also get the idea of data efficient fine-tuning. Because your model has already learned from so much data and seen so much data already, you need a lot less labeled data to achieve state-of-the-art performance. But CLIP is actually just limited to 2D images, and it is also limited to short captions. So in Berlin, we take this approach and we kind of build upon it. We start off by looking at this image encoder, and we think about how to make this image encoder into a volumetric encoder, so that way it can work with 3D CT scans. So specifically, we take this 2D resonant that we have, and then we inflate that up to this 3D resonant and then we keep the same ImageNet weights, so that way we have a strong inductive prior to actually work with. And we apply this using a kernel-centric inflation strategy. So now we have a volume encoder, and now if we want to go to our text encoder, what we're going to do is we're going to take a radiology report, and we're going to extract just the findings from each radiology report, and we're going to pass that through clinical long-former. And the reason why we do this is because long-formers has a really long context length and also a pretty sparse attention mechanism that allows us to reduce the memory usage from quadratic to the sequence length to like a linear scale. And the way we're going to train this is using a principle known as report splitting that we found that works really well. So we essentially going to have alternating batches between the full finding section as well as anatomy-specific finding section. And that is kind of us building out this text encoder. So now volume encoder and text encoder, and this means we've accounted for unstructured EHR in the text encoder as well as imaging data. But how do we account for structured EHR? And we do that by adding in this EHR loss, specifically being able to look at the 1692 phenotypes that we have in our data set. So we begin with this idea of phenotype decomposition using PLOS. And thinks that there are a lot of ICD and ICD-9 and ICD-10 codes, and thinks that there's a lot of redundancy as well. For instance, the ICD-9 code V12.55 and ICD-10 code, also the ICD-9 code 415, both represent like areas of pulmonary disease. And so what we can do is we can actually group all these phenotypes together. For instance, the grouping, we leverage the clinical knowledge of maybe a more specific phenotype that we may have, but we also use all the other phenotypes that are hierarchically, we go upwards from it. So that allows us to take advantage of all the data in there, so that way we keep that same phenotype for the data. And then to actually train this kind of model on the data purpose, we use a fairly large multimodal data corpus. We use abdominal CT scans from 2012 to 2018. There are 18,000 patients from Stanford University. And we use CT scans, EHR data, radiology reports, and we have these kind of splits for our data set. And our data set is fully publicly available. If you would like to use it or look at it for your own purposes, feel free, happy to go ahead and take a look at it. And it was a really big struggle to go through this PHI approval process, but it's the largest open source 3D multimodal data set out there. And we did this all on a single GPU. We had some level of memory efficiencies, design choices to really make it done on how, like just a single GPU. So that way for other people, if they want to fine tune it on their own data set, is much more, it democratizes the fine tuning process a bit. Great, so now we've talked a bit about the training strategy. I'm just going to go ahead and talk a bit about the zero-shot findings classification, which is our non-adaptive task, which is a task that does not need any further training. So we begin with this idea of zero-shot classification. Essentially what we're going to have here is going to have our image that's going to pass through our image encoder, but then we're going to have a series of disease presence prompts and disease absence prompts. So these are prompts that may include partial thrombosis, stable thrombosis, or actual prompts that are indicative of like a positive disease. And then disease absent prompts are specific like things that which we say like no occlusive thrombosis or no thrombosis. And the goal here is that if your disease presence mean cosine similarity, which is a measure of how well your image encoder and your text encoder prompts align well together. Let's say if the disease presence cosine similarity is less than disease absence mean cosine similarity, then we're going to have a negative prediction. And overall, the summary is that zero-shot findings classification assesses Merlin's ability to classify the presence of common imaging findings, which are going to be actually distinct prompts that we're seeing during training. So just to get a sense of all the different diseases, there are a total of 30 different diseases. This was selected from a consensus from 3 different radiologists. I'm comparing here Merlin. We also have the idea of report splitting without splitting, which is just an ablation. We have our external performance across all these diseases, which seems to work fairly well across these diseases, and then our actual baseline, which is a 2DD3 environment clip, which does not do it very well across all these different diseases, meaning that it doesn't have as much capacity that was built in. Whereas Merlin has a lot more capacity just because it's a direct measure of just how well your pre-trained works. But this is a measure of capacity, but we also made this task into a measure of capability. So we converted this zero-shot task into a supervised task. Specifically, we took the radiology reports and all the different finding sections, and we converted it into the 30 different diseases to actually figure out label values for our actual fine-tuning task. And when we have 3 different labels, we have positive, negative, and missing. We only do the actual backpropagation for our positive, negative labels, and this is just a measure of direct capability.
So, I know you're using these terms and they may sound obvious, but could you tell us what the differences are between capacity and capability and what you mean by them?
Yes, so that was this slide.
Maybe I missed it, I apologize.
It's a great question. So it's just this term over here. So it was a stage 1, which is just considered a pre-training, which helps us teach capacity. This essentially is just where you're not using any actual clinical labels, you're just using the data itself so that the model works, the data distribution. And then in stage 2 is capability. This is where we have labels. In this task over here, we are getting labels from our actual fine-tuning. So we created those labels from the radiology report. And that's where we're measuring capability.
So in a simple term, we say image plus text is capability, just image alone is capacity or something?
It's not exactly like that. It depends on the labels. So if we go to this figure right here, whenever you have the pseudo labels and you're training your model like that, that is what's going to give you that pre-trained model, which is going to have that capacity. But whenever you're going to have a lot less labels, and these are perhaps higher quality labels, and that is what's going to give you that capability. So it's this 2-stage approach in which your first stage is a level of pre-training for building that capacity, and the second stage is your fine-tuning for building that capability.
And do you have actual labels for all your pseudo labels?
Yeah, so that's why we put it into positive, negative, and missing. So that way we only train on those that are actually positive and actually negative. So it's a higher quality fine-tuning for us to work with.
So what do you lose by not having a gradation? Makes a big difference. If there's a little pleural effusion or a lot of pleural effusion, a little atelectasis or a whole lobe, and you're dichotomizing, which is probably losing information.
Yeah, so there's other tasks in which you can measure the granularity. But right now, this is just based off the radiology report. So if the clinician has said explicitly no pleural effusion, or there is pleural effusion. So it should be there inside the actual report.
If you said a little pleural effusion at the base or halfway up the lung fields, you'd code it the same.
Not
Yes,
necessarily.
pleural effusion.
So our actual prompts to actually measure if it was positive or negative, I mean, it was very explicit that it was there, or if it was not there, it was very explicit that it wasn't there. We had certain regex characters that we designed with radiologists to make sure that it was very specific to that.
I'm just concerned you're losing a lot of information.
No, it's a fair concern, but I think for this task, it was just for that ability of, because that's what we have it over a lot of different diseases. So that way we have that specific labels out there.
As a clinician, I find most things are not yes or no.
Yeah, I understand. Yeah, so after doing this kind of task, we then compare against a lot of different baselines. We have around several different baselines consisting over different 2D, 2D, 3D, as well as 3D architectures. We also compare against models from Microsoft as well as Google to give a comparison of testing their performance on our data set. And what we really see is both in this idea of 10% data or 100% data that Merlin does really well on this task across the data.
What's the y-axis?
The y-axis over here is AUPRC, over here is AURC. Let me just cut off from the screen.
That's like a area under the curve. Like
So
the
it's
alpha.
area under recall overall. So it's AURC. So it's a bit better than just like a simple AUC.
So 0.7 means 70% accuracy, 70% predicted value. What does it really mean for
Yeah,
people
so it's
who
like
do this for?
it's around like 70% across the area, across all the different thresholds that you create. So yeah, you can just think about it around 70%.
100% is perfect, 50% is chance alone.
Yeah, 50% chance.
And normally, when, for example, in other areas of medicine, when people are developing biomarkers, a 70% or 0.7 AUC in an experimental setting or a very controlled environment translate to flipping a coin in the real world. So 0.7 may look great here, but it may not in the real world. You haven't, I think, had a chance to test this in the real world yet.
No,
Or
it's
you assume your data set is the real world, I guess.
Yeah, I
And
mean-
then it's a question of what real world.
yeah, exactly.
Because the study coming from Stanford said most of these databases
Right,
are
real
very
world is a community
selective.
hospital.
They're from
Yeah,
teaching institutions in California.
No, it's a very good point. We actually did external validation across 45,000 CTs across 3 different external sites. And we've tested Merlin across all these different sites. So really large external validation study. And essentially all you really can compare with is the other baselines. And we found that Merlin outperforms all the other baselines across these external sites. So we've done a very thorough analysis. That's our definition in the research of real world. And whenever we test models, is to see how well does our model perform across different data distributions. And Merlin seems to do really well. And I think a lot of that is because of how high quality Stanford's data really is. So it's really just great to see.
But in your case, like you use like a 5 billion data sets and train them only 15,000 or something, which is around 1.5%. Right? Is that good enough to validate samples, like training these data set based on that with the huge volume of the data sets to convert or predict?
Yeah, so our training data set was around 15,000 CTs.
And also in real world, like many times, these images are not like exactly duplicating or something because the biologically it's like, radiologists, person to person variation will be there actually images. So within that, like you can see the lots of variation or like, error values are there, right?
Yeah, there's a lot of variation. There's a lot of given age variation.
So do you consider that within this 1.5% interpersonal or inter-radiologist variation, you also take it into consideration or something like?
Sorry, I'm not sure I fully understand.
Yeah, the training data sets, right? 1.5%, right? So this is just like absolutely you're taking images, right? So he is a physician, that like between the radiologists, data collections or like you say like based on the radiologist positive is positive, negative is negative or something, right? Within 3 physicians or like radiologists, difference may be there, right? So are you considering that one in the training
So I
data?
think what he's referring to is inter-radiologist.
Yeah, basically inter-radiologists.
So the thing is that this is for a clinical data set, which only typically you have one radiology report. So this isn't like a study in which you've looked at like for each individual report, 3 different radiologists are reading that report. That makes sense. The data is clinical, right? So it's going to be whatever is the actual radiologist reading from that actual image. So 15,000 is, you're saying images, but it's actually a lot of multimodal data. So you have both EHR, ICD codes, as well as radiology reports. So that's why all of that data paired together is what gives a really rich representation, because you're talking about millions of combinations and millions of pairs at that point. So even in terms of like slices, it is still over like 6 million slices for the actual model. But because we're processing it in a 3D way, it allows you to capture a lot of that volumetric context as well.
Is this good performance driven by the positive findings or the negative findings, or it is based on both?
Yeah, it's just based on both. Yeah, it's just able to accurately classify them. So the way you actually do this is you train a very simple linear probe. This is really lightweight. The goal is to not actually train. You just keep that model pre-trained and you're just training a very small linear probe. So that way you already know kind of the goal is that it already has an idea of what the diseases are. That linear probe just slightly extracts that information out of it.
And in the remaining errors, are there more about negative finding that were classified as positive or positive findings that were classified as negative?
Oh, I see. Yeah, it was mostly positive ones that just not actually classified.
So you're getting false positive.
False positive, exactly.
Yeah. But this is like a case in which, like a lot of these models, right? They just end up classifying a lot of things as negative. But of course, you can probably improve. You can improve this performance. This right here is just from a simple linear probe. If you were to actually improve it even more, you could fine tune the whole model. And we've done that. It does increase the performance. But for a fairest comparison, you just train a very small linear probe. So the goal is just to see how good is this capacity, right? That is how a lot of machine learning is doing. This is not to say that this is like fully clinically ready. We can do a lot of other architectural modifications to actually make that happen. But the goal here is to compare to other different models, how testing the capacity and testing a very small set of capability. So that was a little bit about zero-shot finding classification. You now take a look at diagnosis code prediction. And the goal of this task is to use CT scans to directly predict phenotypes. So based on the IC groupings that were assigned to patients during their hospital admission on the CT scan. And what's really interesting is that we note really high AORC across a lot of prevalent disease groups. So this is a case where there's AORC. And the thing is that there's a lot of phenotypes that are actually related to abdominal CT or abdominal pain. But there's also these phenotypes that are perhaps not exactly related to the abdominal CT that your actual image has some understanding, like your actual model has some understanding about. So things like substance-related disorders, or even psychological disorders, or even diabetes and bacterial infection. And this is the real benefit of pre-training with a lot of multimodal data, is that your model starts to understand that how all these things can be related and kind of link that all together to the actual imaging.
Again, your areas under the curve are not very impressive. You're showing me 0.6, you're showing me 0.5, you're showing me 0.7.
So all this is about relatively around greater than 0.7. So I think that is also like, if you look at other models, right, this is also all relative, right? I'm not saying that this is going to be a perfect clinical task, right? This is also research, right? If you were going to design a clinical model that is great on this task, you're going to be doing a lot better, you're going to be doing a lot of different tasks or even different model training to actually do that. Right here, we're just saying what you can achieve straight out of the box. We're just having this model trained on a lot of different data. And for us, and looking at the literature from research, this is very impressive, especially when you compare it to other models, right? So these are also other models that are just trained on this task. So these are a set of 2D models that you kind of train. And you see a lot of them, they even get 0.5 and below in terms of AORC. And there's also other models. So like MedImage Insight, these Google models as well, that are not doing as good as Merlin on this task. And remember, the goal here is that you're just having a small linear approach that you're actually using to actually train this model on this task. So it's really just trying to measure your idea of representation quality. So how good is this pre-training that you have? And you're testing to see how good that capability really is. And there's a lot of other non-adaptive tasks out there that we also do cross-modal retrieval, but I just wanted to hone in on this 5-year disease prediction task, which is what we did for this adaptive task. So in terms of 5-year disease prediction, you're going to have an image encoder, and we have we chose 6 different chronic diseases based on their prevalence and potential for early intervention. So these were diagnoses such as chronic kidney disease, diabetes, hypertension, heart disease, and even cardiovascular disease. And what we observed is that Merlin pre-training seems to offer a lot of benefits for 5-year disease prediction. Right now, what we started off is looking at more of a methodological evolution. So we've looked at just starting off with this random initialization of our model. If we were to start pre-training from scratch, instead of using ImageNet weights. As you can see, it's around there. It's not doing super great across all these different diseases. ImageNet initialization seems to do it a bit better. And then Merlin seems to have a bit better performance across all these different tasks. So that was a real benefit that we saw, is that we can use this model. You get this out of the box. It's learning from all this kind of data across Stanford. And you just train and you fine tune the model and you attach this linear probe to it. And it is still very interesting that you're able to get some kind of signal to learn this kind of information and learn this kind of disease labels.
So 5-year disease prediction means that the individual did not have the disease at the time of imaging
Yes.
and developed it within the coming 5 years.
Yes. So we set it into, we compiled the data into 4 different classes. And some of these things are where patients, we made it explicitly where the patient did not have disease to begin with at the actual stand of the emergency visit. And then within that 5 years, they did develop it. So it was learning that task from that subset of data that we had.
It really is saying you didn't detect the disease at onset, not that the disease wasn't there. Diabetes didn't come on overnight. It didn't come on into 5 years. It probably was subclinical pre-diabetic at the time. And what you're doing is predicting who will get a diagnosis of diabetes, not develop the diabetes. I don't think the diabetes developed in that window.
Yeah.
Cardiovascular.
It is detected.
So it's a subtle difference, but as we get better and better interpretations of your initial test, it's going to change the results.
Yes. Yeah. So this is just an overview of Merlin. There's a lot more tasks, but I know that this was only supposed to be like a short presentation. What we really saw is that Merlin can really generalize to a lot of downstream tasks. There's around over like 752 individual tasks in the actual paper. We went over non-adaptive tasks, which were tasks that we didn't really fine tune or have any sort of, we kept it from the pre-training. And we also have these adaptive tasks. And hopefully this is a good overview in terms of understanding the idea of pre-training, which is what we do, or self-supervised learning, which is a way for us to really like data without and making our own pseudo labels. And also the idea of adaptive tasks, in which you have like a very specific set of like in your head, and you're trying to understand like how you can use this kind of huge representation and model that you've built for your specific task. So these are some main takeaways that we had from the paper. We saw aspects of vision language pre-training outperforms vision only pre-training. I think a lot of these takeaways are very ML specific because they're related to our architectural tests and revelations for our tasks. We saw that 3D vision only pre-training outperforming yielded stronger performance than just using 2D models. And trying to use those 2D to understand the 3D information was not always the best. And just using your standard like 3D volume, a 3D model that can handle the whole volume seemed to be better. And we found that our embeddings were a bit more information rich than the Google CT model, and also Meta Insight. And what was really cool to see is that Merlin outperformed other baselines in both few shot. So these were tasks in which you saw like 10% data versus 100% data. And some of the main benefits of self-supervised learning is that whenever you don't have that many labels, you can still get really good performance. And that is what we saw as well. Being able to pre-train on all that data means that you can use less label data to actually get really good performance. And we wanted to say that Merlin is fully open source. There's over 140,000 downloads to date. The code is fully available. The model is fully available. The data set and paper are all out there. If you want to use it for your own research purposes or explore with it, it's very simple to use. You just pip install Merlin and it works well.
Very nice work. Where do you go next with Merlin? Are you fine-tuning the model? Training it on what specific data sets? What are your plans?
I think the goal is to think bigger. Think about what other aspects, what other applications that they are. We're trying to work on applications of looking at all of Stanford's like imaging data and trying to see if we can train a huge model on all of Stanford's data. So I think the goal is to like think even bigger of like what better methods can you create, right? If you're going to work on all the data, there's going to be some more additional facts that you have to tune. Merlin was really really good proof of concept of a lot of these strategies. We show that, like you were mentioning, it's 15,000 actual images that were used for the training data. So think about not just 15,000, but maybe 1.5 million, right? And what can you really learn at that scale?
So I'm getting at one major endpoint that you're missing is cancer development. So if you look at causes of death, cardiovascular disease and cancer in the neck and neck at 25 to 26% of all deaths. So you're missing one big slice of the pie. I'm wondering, you selectively did not want to look at cancer as an endpoint?
So that's a great question. We're actually working on cancer now. We've developed an oncology-based model for oncology-related tasks and hope to publish that out soon.
Working?
Yeah, it's doing pretty good.
Now, that's compared to other thing, cancer is the most important thing, like that's what, you know.
For some of us.
Of course, like, you know.
So the thing is that cancer has its own unique like issues, right? We're working on, we've looked at Merlin now on lung cancer, right? So we have this huge longitudinal lung cancer data set. And the thing is that there are certain architectural changes that you have to do, right? The real benefit of why we chose the diseases that we have in Merlin is because we wanted to be able to look at all the data, right? And the things that you're going to have to make some sacrifices, right? You may not be able to use the highest resolution image during training, right? Like you may have to downsample your image for your lung. Whereas for cancer, you may want to make it a bit more tiny and a bit more specific, so that way you can learn these fine-grained features. Merlin is a great coarse-grained model. It has a great sense of global information that is inside the images, that is inside all the other data as well. And that's why it gives a great starting point for other people to like start up. And that's why we call these things as like a foundation model, because the goal is that it knows all different aspects of things and you can use it for maybe a specific task if you want it for chest, if you want it for head or something, right? It's just a good sense. It learns images, it knows what diseases are. And that's why people seem to like it. But of course, with cancer, you're going to want to make it a bit more specific for cancer specifically. But right now, the goal of this paper was to think about how do we create a large scale method, right? And how do we make this, how do we see that if this kind of method is possible to look at all different kinds of multimodal data? And of course, nowadays, if you were to redo it, you'd probably change a lot of different kinds of architectures and methods, which is what we're doing now.
So I understand the goal of trying to replace a radiologist or make up for the deficit in radiologists by having an AI system that would read these CAT scans or whatever they are with high accuracy or high whatever number you want to give it. The question I have is whether we outperform or fix the problems that we have when a human is looking at the X-rays. For example, inter-radiologist variability or missing diagnosis. So do these models do that, or is this a premature question?
That's a great question. So one of my the other co-first
It's not
authors.
possible that all questions are great.
No, no, no.
I appreciate that you said that.
Yeah.
Another co-first author from this paper and another student at lab, they actually started a company to do this, and their company was recently bought out by a huge radiology outpatient clinic. They're able to identify really specific diseases, and they're a great demonstration of how you can use these models at scale. So thinking about training on these massive data corpuses, and
Right.
it does seem to work really well. And radiologists really are using it in the clinic and stuff.
Definitely useful, I have no doubt about it. And then my other question that's due to my ignorance, the difference between teaching something on vision only versus vision and language. I thought there's always language involved. Otherwise, how would you associate vision with a diagnosis?
So it's a great
Can you
point.
explain that?
Yes. So one of the components I was mentioning was this idea of contrastive learning. And back in like the day, so I'm talking about like 2020, 2021, a lot of these methods were actually really applied to just vision only. So the goal is how do you essentially get really augment your image in certain ways so that we can create your pseudo labels from just the actual images, so that way you can learn interesting representations from just the vision. But the thing is that we have multimodal data, right? We have language as well. And so it's really a natural way for us to train our models is to pair it with a semantic context. The thing is that this is really useful if your actual goal is to have some level of labels or actual like tasks that require some level of what we call semantic understanding or some kind of language understanding. If your goal is just to have a really good vision sense, right? Like, for instance, segmentation is a great example. Segmentation actually does really well with just using your actual medical images. And you don't need language information for those kind of tasks. So it depends what kind of tasks you're interested in, and it depends what your use case is actually doing. And I think that's how you would weigh versus using language data or not. Because acquiring language data is expensive. And we're very fortunate here at Stanford that we can get this kind of data, I say relatively easily, but it is relatively easy compared to other institutions.
Right.
So that is something to keep in mind is we're very lucky as researchers to be able to have access to this kind of data.
And then as a follow-up to the question of what's next, what can you apply this to next? So I can tell you where I'm coming from. So when I listen to these lectures, and I'm far from an expert, what I hear is what you've created is an amazing parrot in the box. Meaning it's like parroting the information and creating a report much faster and much more efficiently than a human. The question that I have is whether it can discover new associations. So for example, it looks at a CAT scan and says, if I have these 17 anomalies in this CAT scan, this implies this, not that, something that humans have not done before. So can it go to where humans have never been?
This is actually a great question. So another postdoc in the lab, Robbie Holloman, myself, we've been actually working on trying to discover novel biomarkers from this data set.
Right.
We've actually looked at 50 different prognostic markers, and it showed to like we looked at both images, radiology reports, and lab values as well. And it works. You can actually like look at it, and we have a really nice method of like being able to discover new concepts as well. And if you want to learn more, you should talk to Robbie about his work.
Thank you.
So it's really cool. I feel like all the questions that looked at, it's like very nicely pitched to other work in the lab because these are stuff that we've been considering for several years now, of trying to figure out what we can do and how do we really like to make the next generation of medical AI.
And I think you've maybe mentioned it or been alluded to, so you can apply this to other imaging modalities. Things we use in research, for example, let's say spatial transcriptional analysis or imaging that we do in the lab. You can apply that.
So you can apply the method, right, that we use here. Like Clip, if you have like actual labels with your data, then you can do it. There's so many different kinds of methods. If your goal is to build that kind of pre-trained representation or the capacity that we say, there are several methods out there that have been developed over the last 5 years to be able to do that on all your different kinds of medical image data or just image data or just like your text data or anything, right? So a lot of techniques have been built out there.
Sorry,
No, it's okay. The layman question, like if I give some 100 positive imaging data sets, applying Merlin model, like how much you feel like all 99.9% you will get predictable, or like you will have some only certain percentage? If not, why, and what is the next level to improve the 100%? So to avoid false positive or false negative.
Sure. That's a good question, but I think it really depends on the task, right? There are some tasks in where we saw in which, let's say it's splenomegaly, right? That is like enlargement of the spleen. Whether it is super clinically relevant, it depends on the patient or not. Your model can do, we saw it's like close to like probably 95% for that. But many other tasks that are perhaps a lot more fine grained, like very small lesions, like if you have in your renal, like very small renal cysts, maybe it doesn't do so well, right? So I think the goal is to like think about, if you were to think about Merlin, is how do you create this model so that way you can think about both coarse grained information from your imaging features, but also some very fine grained information, right? And I think that would be probably the next step to increase that performance, is to combine all that information together.
Do we have a question online? Can they speak up, or can we hear them, or should I read? I'll read it, no problem. So this is a long question. I'm sure it's a great question. Says Ashwin, thank you for this wonderful talk about what you have done and what is happening at AIMI, right here in our report. On the one hand, it seems that AI has generally taken data that is retrospectively available and attempted to find a signal from within the noise. On the other hand, interventional studies are deliberate about what data are going to be collected and sometimes data requiring non-clinical data, for example, various omics. Is there at present a middle path to recommend to medical systems to maximize predictions and treatment care for all comers as patients? For example, incorporate existing data plus limited serum proteomics.
That is a very good question, but I don't think I have all the domain knowledge to fully understand that. I will talk a bit about that idea of prospective data. And I feel like, so there's this actually professor, there's a large scale trial done at Columbia in which they looked at trying to use these models in the clinic and trying to see if that actually helps improve. I think the actual application was cardiac amyloidosis. And they found that the model was really good. It was actually, you may think of like a lot of these models as having a bias, but actually the models helped actually reduce bias in their study. It helped improve like Black patients' diagnosis of cardiac amyloidosis. And it seemed to work really well. So that was an example of perhaps where you train on retrospective data, you're actually using it for prospective data.
Yeah.
In terms of using it for actual other modalities, I don't know specifically about spatial proteomics and combining with all this imaging and stuff like that too. But what I do know is that there are a lot of research being done on how much can we take multimodal data to. And it seems like the limiting question isn't the methods to do it, but it is whether we have the access to the data to do it and whether the data is high quality enough. And so I think like if we keep getting that enough high quality data, right now we have access to a lot of clinical data because that's where we are in a lot of hospital systems, and that's where a lot of these like radiology AI groups also work is within these hospital systems. So you're going to mostly see imaging plus these kind of text and these other kinds of data. But of course, adding more data, genetics, spatial proteomics, whatever other data you want, it would be great to add all of this stuff together because that is how you build the richest representation possible.
So the question was here about adding wider modalities. But now in some other fields where all the experiments to have baseline predictions have failed, there are new studies showing that okay, you cannot rely only on baseline predictions, so you have to add like on treatment like week 4, week 8, week 8, which sometimes alter the baseline prediction. So is that, do you think that would overperform the only baseline here if you only looking at like if you look at the evolution of the images?
So just to get your question, right, you're saying if you had labels at intermediate time steps, and that could potentially improve your
improve your baseline, yeah.
Yeah, totally. I feel like you add in much more signals and you add in higher quality labels, that's going to help your model, right? We talked a lot about, again, I go back to this idea of capacity and capability because it's pretty broad terms, but you're going to improve your capability even more if you have that much finer grained labels, right? And your labels are going to allow you to better assess your actual capacity as well.
What meant this change over time?
Oh, okay.
So let's take a tumor, for example. A tumor growing at a certain rate is unlikely to be malignant versus one that's growing at a faster rate. I would guess that mathematically that should be easier.
Also, the biomarker changes are very predictive. Cell-free tumor DNA, the rate of decline, CA125.
Is that what you meant?
Yeah. I mean, it's better for all fields, for all kinds of prediction models, whether it is multimodal or just one biomarker, not to present it to people, public and clinicians, just like baseline.
Yes.
Because it will always be improved if you provide something after the 0.0, whatever it is, starting treatment.
Yeah, in college, it's what we call adaptive therapy.
Yeah.
So if we see the tumor is growing after 3 weeks, probably it's not great to continue the treatment, to switch.
So regardless of baseline prediction.
Regardless of baseline prediction. So as you say, the more you get, more, of course, it introduces bias because you already started treatment, you already wasted a certain amount of time, and you already got selection of who's responding and who's not.
Indeed, but then you have another end target.
Right. And it's used clinically in oncology.
All right, that was wonderful. It's a huge accomplishment for someone at your stage and presenting the whole issue. We really appreciate it.
Great answers.
I apologize. We appreciate that. You asked a bit
It's very good.